So we're going to take a look at the key components of treatment. Modalities of treatment for eating disorders should be evidence-based and target behavior change over insight. And I love saying this to my patients. I like to ask them, what other kinds of therapy have you done before you've come here? And I like to tell them how what we do at ERC is going to be either similar to or different from those experiences. We believe, and we'll talk about why, but we believe that behavior change is our primary target of treatment. Our job is to help that person stop the behaviors that they're having, learn coping skills, and move forward, doing things differently. We focus on action, we focus on intervention behaviorally. In the beginning of treatment, while a person is still actively engaging in behaviors, we don't talk a whole lot about their childhood. We don't talk a whole lot about trauma they experienced. And that's not because we don't think it's important. It is critically important, and sometimes it can be a maintaining factor of the eating disorder in the here and now. However, if I have a patient who's actively engaging in their behaviors, my focus needs to be somewhere else. I need to focus on how do I help you stop your behaviors right now? Because people can die waiting to get insight. Our head dietitian has a story that when she was first practicing in Mexico, she worked with a psychiatrist who was treating a patient, and he used an insight-oriented model and treated this patient for 10 years, and the patient ultimately died as a result of her anorexia. And that doesn't mean that that doctor wasn't doing the best that he could or providing the therapy that he thought was helpful to that patient, but it was not a behavioral therapy. And so I think it's hard, because patients have usually experienced very painful things in their lives. About 80% of our patients have some sort of trauma history. So we try to be trauma informed in every interaction with every patient. And at the same time, I believe, and the rest of the team believes, that the most compassionate thing that we can do for our patient is to first help them stop their behaviors and to help them learn how to cope differently, help them get new skills, healthy coping skills, and then address the things that are painful. And so sometimes that can come off a little, it can be a little rough, at first, because people really, they really want to talk about how they feel, and that's really important. And so we work really hard to prioritize and to use modalities in our treatment where we can both help them feel emotionally okay, but also make sure that their feet are set on the right path that's going to ultimately take them into long-term recovery. So the modalities that we use at ERC are acceptance and commitment therapy, or ACT, dialectical behavior therapy, and family-based therapy. And all of these are, again, evidence-based. There's lots of research that supports their effectiveness. And they focus on values, teaching healthy coping skills, and intervening in problematic behaviors. There's a lot of great resources out there about these three types of treatments. And there's lots of learning opportunities and workbooks and things that are really helpful. One of the things that I like the most about evidence-based treatments and manualized treatments is that they're so egalitarian. Everyone has a fair shot at becoming a really good ACT therapist. There's no secret knowledge at all whatsoever. And so it's a really very democratic kind of a feel when everyone on the treatment team, no matter when you started or what your background is, we're all working together to stack hands in this one therapeutic modality, and we're all learning from the same book, and we all have a fair shot at it. And the patients benefit from us sharing a common language as a treatment team as well, because then they learn the language that they can use to talk about their own recoveries. Another key component of treatment is a multidisciplinary treatment team. So what we found and what the research shows is that teams including medical doctors, psychiatrists, therapists, and dietitians are the most effective at providing treatment for eating disorders. And this can happen as this might be an outpatient team, potentially if a person has a low level of severity of their symptoms. Or this could be a team like we have at ERC. In our PHP, we have all of these pieces, and all of our patients see each of these providers every week and have them looking at different aspects of their recovery. I'm no dietitian by any stretch of the imagination, and so having our dietitian come and talk to me about something that my patient needs to work on in individual therapy as part of that behavior change approach is absolutely invaluable. I don't think we'd make the progress that we can make without that part of our center. Early intervention is key. We want to provide treatment for people with eating disorders as soon as we know about the eating disorder. People who are given early intervention have the best prognosis for recovery. In tandem with that, appropriate level of care is really critical. Obviously, levels of care range through outpatient to inpatient, and all kind of flavors in between. What we find is that having a patient at the appropriate level of care for the severity of their illness actually can shorten their treatment stay. I can have a patient at PHP for 4 weeks, do the work they need to do, that would have taken them 3-4 times that long in IOP or outpatient. So a lot of times what we find is that when patients start to, if they have an experience of not making progress or their outpatient providers are feeling stuck with them, that could be an opportunity to think about moving to a higher level of care. Higher levels of care, I think, are scary, and they can be very stigmatized. But what we find is that, again, it can actually shorten the length of their treatment stay and can help them make behavioral changes more quickly so that they can begin building a lasting recovery for themselves. And a final key component of treatment is weight restoration as needed. There is no such thing as treating an anorexic patient who's underweight and not having them gain weight. That's not successful treatment. And I've had many, many patients try to convince me that, if I can just stay at this weight, I can eat. I can be totally fine, and I won't engage in my behaviors, and it's gonna be fine. I just don't wanna gain weight. And unfortunately, that's not part of the deal. One of the quotes that our head dietitian uses that I wanted to include is this from this story or this article by Garner. Trying to make meaningful psychological changes with an anorexic patient in a starved state is analogous to trying to address underlying issues with an alcoholic patient who is intoxicated. Doing therapy with a patient who's significantly underweight is treading water, unfortunately. Our patients, when they're that underweight, like we talked about, their cognitive processes are not online, everything's fuzzy, their decision making's impaired, their body is biologically stressed, and only until they reach their healthy weight, their healthy ideal body weight, which is, again, remembering very, very narrow window there, are they really going to be able to dig in and do the intensive therapeutic work that they're going to need to do for long-term recovery. And that's not even usually something, at ERC we have PHP and IOP levels of care. When I discharge my patients from IOP, I'm very clear with them that their work's not finished. And that's why we refer out to outpatient teams, because we know that they have a long road ahead of them. But they're finally at a stable weight, and their body's healthy, and their brain has nutrition, and they can do the work. So a lot of times it's really tempting to kind of see the picture and want to do the work right then. But the behavioral intervention and redirection is the most important thing. And weight restoration for our underweight patients is the most important thing. Just because you're weight restored doesn't mean you're recovered, but you can't recover until you're weight restored. So it's kind of a catch-22. So a few closing thoughts. remember that eating disorders are serious mental illnesses with potential lifelong physical consequences. Intervention should be early and intense for the best long-term prognosis. Weight restoration is essential for therapy and medication to be effective. Ambivalence about the severity of the disorder and/or the need for treatment is a symptom of the illness. And if in doubt, have your loved one evaluated by eating disorder specialists. Never hurts to find out. Thank you all very much. So I'd love, if anyone has any questions, I'd love to answer those for you.
Yes. What causes the competency in reality or anorexia?
It's a very strange, so the question was, how does an anorexic patient, how are they able to be really competent in their life but not be able to be competent with food and body? And it's, I don't think there's like an easy answer for it. I think it's just the way that the eating disorder is set up. It's just the way the illness is set up. A lot of times the temperament styles of the patients are perfectionistic and anxious, and so they're always kind of like the straight A student type and the good child. And so a lot of their temperament is kind of floating that ability. But then the eating disorder just hones in kind of on this very specific part of what they do. But at least until the eating disorder progresses significantly, it leaves most of that untouched.
Yes. Quick question. So for the diagnostic criteria for anorexia, there's a fear of losing weight or something like that. Yes. So they're verbalizing that always. Not always. They're also trying to hide it and keep it and lie about it, and it's tough if you're not admitting that, no, I feel like it's fine, or you're not letting on to that issue.
Right, absolutely. Yeah, no, that's such a good point, because they're not always upfront about it, right? Because remember, the eating disorder wants to fly under the radar and not have people like butt into its business, so to speak. So it is really difficult when a patient, is actively, you see them losing weight, their numbers are dropping, and they're like, no, I feel like I look fine, it's fine. In those situations, what you do is rule out other medical issues that could be contributing to the weight loss. And then if they're clear on medical issues, then they need to get with a dietitian and start on a weight gain plan. And if they're not able to gain weight, then it's time to ask more questions.
I work at a children's hospital. There's a lot of patients I work with have like Crohn's and colitis, like stomach issues. So there's a ton of anxiety related to eating already because it hurts and it's vomiting. But then we're seeing our patients like pinching their tubes and restricting, and it's like it hurts. But at the same time, it's like extreme behaviors and the weight swapping and right. It's tough. And do you guys take patients who also have medical diagnosis?
We have, yeah, we have. As long as they're medically stable, we can treat them at our facility. We have, I think, there's a really interesting article called the Ansel Keys study. And it's this study, it's like our head dietitian's most favorite thing in the world, and it's amazing. It's a study from World War II where they took a population of healthy men and put them on a starvation diet to see what would happen. And I think they could elect to do this instead of being drafted, I believe was the context. So not much of a choice, right? So they found that as these men who had no pre-existing eating disorders began to lose weight and became underweight, they actually started having eating disorder behaviors. So there's evidence, and in other research studies as well, there's evidence that even if you didn't have an eating disorder to start with, having a significantly low body weight can actually activate eating disorder behaviors. So even if they're losing weight because it's hurting, if they get low weight enough, they actually are at risk of developing an eating disorder.
Yeah, absolutely. Anyone else? Yes.
How willing do the patients need to be to enter treatment?
It's okay. So that's
Does it work if they're not willing, but the parents really,
So our program for our adolescents is a program that relies really heavily on parent involvement. So we really focus on training the parents to keep their child healthy until the child can reach an age, a developmental age, where they can choose to own their recovery for themselves. So I would say that the majority of our adolescent patients are pretty unwilling participants, unfortunately. But you know, that's nothing on them, that's the eating disorder, right? So our adult patients, of course, it matters more because they have like autonomy over themselves and they can sign themselves out. So it helps if an adolescent or an adult patient is unwilling, that they have a strong support network who's kind of pushing them to go back every day. But just because a person isn't willing doesn't mean that they can't make progress. I think a lot of people start off saying, I'm just doing this for my family, or I'm just doing this for, you know, my job or whatever it is. And they find, as we work through values and coping skills and kind of digging in, they find reason to want it for themselves. Yeah, so I think, I mean, willingness is always helpful. That's like kind of a bonus, I think. But I don't think it's a necessary requirement to enter treatment. You're welcome. Anyone else? Okay. Thank you all so much for having me today.